Hello, everyone. My name is Sandeep Nathan. I'm an interventional cardiologist at the University of Chicago Medicine and an associate editor of JSCAI. I'm here today with Dr. Tayyab Shah from Yale University School of Medicine, who's the first author on the paper, Mechanical Circulatory Support in Myocardial Infarction Complicated by Cardiogenic Shock, Impact of Sex and Timing. I'm also joined today by our panelists, Dr. Cindy Grines from Northside Hospital Cardiovascular Institute in Atlanta. Welcome, Cindy. And Dr. Alexandra Lansky from the Yale University School of Medicine. Cindy, you're also an associate editor for JSCAI, and Dr. Lansky, you're the editor-in-chief of JSCAI. So welcome, everyone, and thanks for being here.
Thank you.
So I think I'll start off this discussion by turning it over to you, Dr. Shah. Can you maybe start by summarizing the methodology and some of the key findings of this paper?
Yep, absolutely. Let me just share my screen here. I have a brief PowerPoint to show.
Absolutely.
All right, excellent. So thank you, everyone. It's my pleasure to present this paper on behalf of all the co-authors. Just quickly going over disclosures, I've received a prior speaking honorarium from Abumed, the sponsor of the RECOVER-3 study. A little bit of background. Prior observational studies in acute myocardial infarction complicated by cardiogenic shock have shown that the timing of Impella implantation and sex play a key role in subsequent mortality. The goal of our study is to assess the impact of these two factors on AMICS patients undergoing PCI. In terms of methods, the RECOVER-3 study is a prospective multi-center single-arm post-market approval study enrolling all patients with AMICS treated with PCI and Impella devices. Between 2017 and 2019, we enrolled 358 consecutive patients, 21% of whom were women from 45 different sites across Europe and the United States. Jumping into the results here, the first thing we found was that women were more likely to have more severe hypotension than men. In the first two rows here, you can see that women had lower diastolic blood pressures and mean arterial pressures than men. These pressures were measured as soon as the latest possible measurement before the Impella was implanted. So these included when patients were on inotropes and vasopressors. The second thing we found was that women were less likely to receive aggressive interventions. For example, women were more likely to have intra-aortic balloon pump placed instead of the Impella. And then women were also less likely to receive the Impella CP device than men, which provides more cardiac output than the Impella 2.5 device. Similarly, women also had a shorter duration of device support than men. And then in terms of lab values, women were more likely to be anemic at the time of presentation. The other thing I should point out is that this was a sicker cardiogenic shock cohort. You can see up here in this row that about 50% of the patients had cardiac arrest prior to the Impella being implanted, which corresponds to SCAI stage E cardiogenic shock. Moving on to the outcomes, the first thing is that there were no significant sex differences in any of the outcomes listed here. The significant outcomes are highlighted here in blue. You can see that mortality was still quite high for this population, around 50%. And then, as I'm sure everyone knows, one of the major complications of the Impella device is bleeding and vascular complications. And prior studies, including an earlier study from the same registry, showed that these rates could be as high as 20 to 30% in some patients, in some patient populations. But here you can see that in both men and women, those rates have dropped dramatically in a more contemporary cohort. The next thing we looked at was the effect of timing of Impella implantation on survival. What you can see here is that timing is particularly important for women. Women who had the Impella implanted post-PCI had a markedly lower survival than those who had it implanted pre-PCI, while this was not seen in men. Similarly, for both sexes, as the number of inotropes pre-Impella implantation went up, the survival went down, but the slope was much steeper for women. And although there was no significant sex differences in survival in patients on 0 or 1 inotropes, those on greater than or equal to 2 inotropes, among those patients, women had a much lower survival than the men in that cohort. The last thing we did was look at the multivariable predictors of mortality by sex. Here you can see the results in the overall cohort with the significant ones highlighted in blue. Most of them are just the traditional risk factors. The one that I want to highlight here is the maximum number of inotropes and vasopressors prior to Impella. That's a significant predictor, while pre-PCI Impella implantation is not down here. That suggests that it's not necessarily pre-PCI Impella implantation that is driving the mortality benefit, but rather early Impella implantation before a patient is more hemodynamically compromised as manifested by increasing number of inotropes. The other thing here is important to note is that sex was not a significant predictor of mortality. However, we did do 2 separate multivariable analyses by sex, and you can see that the predictors by sex were a little bit different. But again, the one I want to highlight is the maximum number of pre-impella inotropes or vasopressors. And you can see that that's the most significant predictor in women with an odds ratio of 3.03. So in conclusion, in our cohort of AMICS patients who received PCI and Impella devices, the in-hospital survival was around 52%, and there were no major sex differences. Women had more severe hypotension and appeared to be treated less aggressively than men. And in women, escalation of inotropes and vasopressors was associated with a dismal survival compared to men, and earlier use of Impella in women seems to improve outcomes without an increased risk of bleeding. These findings speak to the need to establish pathways for care for women with AMICS. Thank you.
Super. Well, thank you for that top line summary of the paper. I think that there's a lot to talk about here. So let me open it up for discussion here, and I'll put this out to anybody. What do you regard as the most important take-home messages for the clinician that's reading this paper? I think we all try to do the right thing for critically ill patients, but this paper speaks to very different treatment pathways for men versus women, how they actually get into the cath lab to the point of Impella implantation. So what would you regard, Cindy or Alexandra, as some of the more important take-home messages for the clinician?
To me, I think, once again, this speaks to some of the disparities between men and women. And, I think Tayyab pointed out very nicely that the treatment seems to be a little bit more delayed and less aggressive in female patients. It seems like we tend to escalate inotropes in women before going to Impella. It seems like we use more balloon pump prior to escalation to Impella. The duration of Impella use is lower. So all these things, I think, again, speak to, differences in our approach to treating women. Another top line that I think is really key here, one of the reasons why I think we may be less inclined to using large bore devices and Impella in female patients is the concern over vascular complications. And I think you can see very nicely here that, in fact, there are no differences in the vascular complications. And we've seen a pretty impressive reduction in vascular complications in this cohort. I mean, it's much more contemporary, but you're looking at 10%. I think historically you're looking at 20% rates of vascular complications. So there's no question that we've come a long way here in improving that complication. So, I think those are sort of high level, some of the issues I think that are really important in highlighting.
Yeah, I agree 100%. And I think it's actually very reassuring that there's no difference in vascular complications. Now, some of that can be due to the fact that they used smaller devices in women. But be that as it may, the women have a good survival rate. And in fact, you've done a lot of research showing that women have higher mortalities just from overall STEMI. And we know that women have higher mortality from cardiogenic shock. But when you have a protocolized approach, supposedly it will reduce those disparities that you mentioned, Alexandra. And also the women here do not seem to have any excess of mortality, despite the fact that they are very sick. And they have the same number of disease vessels, the same low ejection fraction as men. And this is different than what we usually see in a STEMI population. So I'm overall positively impacted by this. And it seems to lead to the fact that we should be more aggressive with women.
In that very sick population, why do you suppose that women presented with a lower diastolic, lower mean pressure? Do you think it was a delay in diagnosis, a lower pre-shock blood pressure, or something else? Perhaps the fact that there was a greater proportion on balloon pumps that were artificially sort of bringing those numbers down, or a little bit of everything. Can you sort of speculate on that a little bit?
Yeah, I think that one of the things that could be contributing to that is basically delays to care in women. What we did find is that if you look at women on 0 to 1 inotrope and you compare them to women on 2 or greater inotropes, that the women on 2 or greater inotropes had a much lower diastolic blood pressure, while if you did the same comparison in men, there was no drop in diastolic blood pressure, even though they're on the same number of inotropes, like relative to the women. So it suggests that maybe we're not only escalating, it's taking longer to escalate women to Impella support, but also taking longer to escalate even the number of inotropes that a woman is on.
Cindy, can you talk maybe a little bit about pre-PCI Impella implantation versus post-PCI? Do we think that there's truly gender-specific differences? And how do you sort of square that with the global CVAD data that suggests that everyone benefits from pre-PCI implantation?
Right. Well, Bill O'Neill showed that pre-PCI placement of Impella is much, much better. Now, we don't really know the exact mechanism for this. It could be that early support allows more myocardial recovery, but it also could be if you wait until the patient is so sick that you're using it as a bailout device, and that just doesn't work. So I think it does speak to earlier placement. The exact timing of that is still up to a question. Now, with regard to women, it's interesting because the CVAD registry, their publication on this showed that women had the greatest benefit from early placement of Impella. And this has been replicated in this current study. So I think that there's enough data suggesting that women do well with Impella that, again, we should not use sex in and of itself as a reason to discriminate against placement of this device. And I think the reason many interventionalists are concerned is because of the potential vascular complications. But we do know that these vascular complications do seem to be better. And whether it's due to the fact that we're, using ultrasound guidance or whatever technique is being used now, what we're finding is that the rate of vascular complications with Impella has dramatically decreased over time.
Yeah, I think that's a really important point, and it's very reassuring that these complications have come down, because I think that's been a real barrier to entry at a lot of places. There was quite a large difference in weight between the female cohort and the male cohort, suggesting that there's probably some differences in vascular caliber and so forth. I don't know whether this data is granular enough to actually look at the caliber of the vessels that these devices were implanted into, but I think, overall, it's nice to see parity between male and female cohorts in terms of complications. And that's not been the case for a whole variety of vascular procedures, right? I mean, historically, women always seem to fare a little bit worse than men with respect to vascular complications. Mm-hmm. It's a very provocative paper, and really important from the standpoint of highlighting healthcare disparities. Is this a testable hypothesis? What other data sets can we sort of probe to see whether the same sort of signals emerge? Are there other ways that we can look at this data?
We've been looking at, and we're planning to look at the premier healthcare database. I think it would be really interesting to look at gender-based outcomes in that cohort. I mean, you can tease out and look at vascular complications there. We're planning to look at trends over time. So, that may be, and hopefully will confirm these results. But you're right. I mean, this is the second data set that is confirming the same thing, right? So to me, I think it speaks to, as Tayyab mentioned, it speaks to the pathways of care and really kind of setting that up.
Another thing that I thought was really interesting is that, if you look at the Black population, so there were 21% Blacks in the female cohort compared to only 10% in the males. And, we wrote this diversity paper, Disparities in Care, pointing out that Black women do particularly poorly when they have coronary disease, whether it's an elective PCI or an emergent STEMI PCI and in cardiogenic shock. And this speaks to that. I mean, the Black women are clearly sicker than the Black men if there's a higher proportion that are getting in here. And so that, again, is another area where we really should focus.
Yeah, all great points. I have one other question that I'd love to get to in the last few minutes that we have. There seemed to be a differential impact of vasopressor escalation in women versus men. I think we can all agree based on historical data that adding on pressors, going to high dose pressors is sort of a terrible idea in ischemic cardiogenic shock and cardiogenic shock in general. But women seem to be somehow a bit more susceptible to mortality if you went the route of vasoactive escalation. Can any one of you maybe comment on that a little bit, shed some light on why that might be? Is it once again the interaction with treatment delays, sicker patients on the front end?
Well, clearly it's, some of this might just be selection bias because the sicker patients require more vasopressors. But, it's very confusing. I mean, in the heart failure world, we give vasodilators and that improves survival, right? And in the cardiogenic shock arena, we give vasoconstrictors. And so the more, theoretically, you're going to increase the afterload and further reduce the cardiac output. But at the same time, you need a certain amount of blood pressure to maintain coronary perfusion. So I think you're walking a very tight line. And we don't really know the answer to this. We don't even know what the optimal mean arterial pressure is. And so there's a lot that's still unknown. And I think that it probably is going to depend. This was all STEMI cardiogenic shock, so that makes it easier. But when you get into the cardiogenic shock that could be a non-ischemic cardiomyopathy or a totally different reason for the shock, then I think the answer to that question probably is going to differ.
Right.
Dr. Lansky, any final thoughts on the subject?
Thanks, Sandeep. No, I think it's really speculation. I think the numbers of patients are relatively small, but I think again, I mean, the observation now is repeated in 2 studies. So, I think we need to pay attention and we need to try and figure this out. Whether it's preconditioning or many other sort of potential mechanisms for this. Final comments. I want to thank Tayyab for a fabulous job in presenting this and submitting to our inaugural issue of JSCAI. We're very excited about this, and thank you for moderating this session. I think this was great.